All right. Good morning, good afternoon, good evening, wherever and whenever you're watching this. I hope you're having a great day. So we are at week 9. I can't believe that already. And I definitely miss seeing you all in person. As part of what I enjoy doing is being with you with all the discussion and questions that you have. So I really hope that as you're watching this, you're writing down your questions, you're bringing your comments to class next week, where I also plan to have a little review quiz again so that we can all kind of be on the same page about the content that I covered today and last week. And that way we also have kind of that review in mind of things that we've learned. This is really exciting for me because I appreciate the people that did fill out the feedback, really do feel like they have a good grounding of the foundational knowledge. So that just lets me know people are paying attention, which is exciting, but also that you're passionate about this. And I'm very encouraged, honestly, because I see in all your assignments the drive and passion you have for your respective professions. You are definitely the hope of the future right now, and especially in the current times that we're in. I really, really am encouraged by you all because I know that by having you in our profession, you're really making a difference by helping clients navigate through retirement, by even your own families helping them through this. I think that that helps break um, generational cycles of poverty, and increase a lot of financial literacy that we need that can clearly affect long-term outcomes. So I'm continuously encouraged by you all. I hope that you are as well. And without further ado, let's get into it. So, a couple of announcements. Number one is that your assignment two is due next week. If you have any questions about that, please email me right away. And then the other announcement is that event that was canceled back in February related to social isolation is back on next week, 12 to 2. And I think it's in McGuinn, so that's the building that we already have class in. So I would really encourage you, especially if you're on campus and you're available, or if you can show up earlier, to come in, get some food, network with people, get great information about social isolation. And especially those who might be outside of our School of Social Work, I really encourage you to come in and see the scholars and network of people that we have so that you can also stay connected in that way. So today we're going to be covering, as I thought about the midterm review we did last week, there's a couple points that I feel we need to cover in terms of housing part two and in terms of Medicaid. So at some point I'll probably be pausing this to then go to the other slides to be able to cover all of that. So we'll be covering housing part two, Medicaid part two, and also aging friendly communities, which I should have added a bullet point here, but just to give you an overview of what I will be covering for today. All right. So last week we stopped at a point where we talked about long-term care and how Medicaid is a huge supplier of long-term care, especially for older adults and people with disabilities. We also talked about briefly about dual eligibility. So let's break it down real quick. So in terms of dual eligibility, there's people who qualify for both Medicare and Medicaid. So it's important for us to know who those people are. There's not a specific type of person, like there's not a one person that kind of qualifies for both. Rather that there's people who qualify for Medicare first, for example, like they reach the age of 65 or have a certain chronic illness and are on Medicare, which then triggers potential Medicaid qualification due to their income or assets being below that federal poverty level limit. Um, so that being said, right, there's the Medicare part and there's also the Medicaid part. Now, it doesn't have to be that someone qualifies for Medicare or Medicaid first. The timing doesn't really matter as long as you qualify for both. You would be dual eligible to receive both. So, quick overview, right? Like Medicare covers hospital insurance under Part A, medical insurance under Part B, private insurance options through Part C, like Medicare Advantage, and prescription drug coverage under Part D, right? Medicaid, on the other hand, we covered last week, is not a nationwide, it's not federally um, run, right? Medicaid, on the other hand, is a joint federal state program. So what that means is that it helps cover healthcare costs for individual with low income, but the eligibility and benefits vary by state. So that's important. We keep talking about how it really matters what state you're in especially to know what benefits you and your clients will qualify for. Um, so like let's give an example, right? And this is an example just as something that you might see in practice with older adults. So imagine someone 65 years old, they recently retired, and this person has a low income, and you know that they have a low income from the biopsychosocial that you do. So you know they qualify for Medicare based solely on age, right? 65. But you also know that this might mean they qualify for Medicaid to help cover. It could mean anything, right? Like Medicaid could kick in to cover premiums, out-of-pocket costs. Most generally, Medicare begins coverage and then Medicaid picks up whatever Medicare does not cover. So that's usually the kind of support we're discussing today. So I want to talk about the different categories of dual eligibility. Not everyone receives the same level of financial support. So the first support or category of dual eligibility is qualified Medicare beneficiary. And I'm going to stop right here too, just to insert and say that I have a link in here that goes directly to exactly where that link of benefits and document is, just so that you know their language about how they go about describing these things. But I summarized it for you here. So essentially, the qualified Medicare beneficiary, usually called QMB, is an individual who receives assistance with both Medicare Part A and B premiums and cost sharing, such as deductibles, copays, and co-insurance. So we talked about how for traditional Medicare, the only mandatory part is Part A. In this case, because someone is dual qualified, and in this category, they do get both Part A and Part B. So that's important, right? Because that's hospital and also private, not private insurance, sorry, the preventive services. So like the medical care, you going to a doctor is Part B. Okay. So essentially, this is the Medicare Part A and B premiums and cost sharing, such as deductibles, copays, and coinsurance. So there are two types of QMBs. There's the QMB only, and this is within this document because I want you to kind of be aware of the differences. Just to summarize, there's QMB only, where Medicaid pays for Medicare costs but doesn't provide full Medicaid benefits. So I'll repeat that because I feel like it's a mouthful. But essentially, Medicaid pays for Medicare costs, but does not provide full Medicaid benefits. Now there's the QMB plus, where individuals receive full Medicaid benefits. So obviously this varies in terms of your eligibility status, but one important rule is that providers can't bill QMB individuals for Medicare cost sharing. So that means providers have to bill Medicaid. You can see how this starts to get tangled real quick, right? The network of how things go, who bills who, what insurance kicks in, which one doesn't. So if you're a QMB individual, so qualified Medicare beneficiary, then, if you're engaged, if a provider can't bill for Medicare cost sharing, so you would have to bill Medicaid. So that's all in the document I'm providing to you. So I won't go too deep into it. And this is again foundational just to give you an overview. This is for you to then take and do more research on your own, especially as it applies to your clients. But moving on to the next category, bigger category, or our umbrella category, I should say, is the specified low income beneficiary. So this type of beneficiary is kind of like QMB, but there's also it's kind of like QMB in that there is two types, like the only and the plus. So like having an iPhone and an iPhone Plus, it's the same thing like the only and plus. And the only basically means that Medicaid pays for Part B premiums, while the plus is where individuals receive full Medicaid benefits. So I feel like that's kind of an easy way to remember it. Like the plus will always receive those full Medicaid benefits on both QMB and SLMB. The only will cover only partial pieces. Like, we talked about QMB only is where Medicaid pays for Medicare costs but doesn't provide those full benefits. SLMB only is where Medicaid only pays for Part B premiums. Then we have qualifying individuals or QIs. And this category is for those whose income is slightly above the SLMB limits. So I'll pause here to say again, when you're dual eligible, because okay, so like you would get Medicare already because you're 65, and in the scenario I gave is 65. So you would have Medicare already. Now, your Medicaid, the type of Medicaid eligibility you would have as a dual eligible beneficiary would really depend on your eligibility for Medicaid. So once you go through that Medicaid process and they determine, hey, this person's maybe at the highest eligibility status, or maybe this person has enough to cover certain things, but not other things, then this is where those different categories come in. So for QI enrollees, they receive assistance with Part B premiums, but these benefits are basically limited to states' availability for federal funding each year. So this isn't a guaranteed thing, right? And again, this is done because these people who are in the qualifying individual category are people who are potentially in their income slightly above SLMB's limits. So that's important. But any help is good help at this point, right? Obviously, there's holes in the system. I say that just because it's good to have some sort of benefit, especially if you need that assistance for healthcare. Now, the last category I wanted to cover briefly was the qualified disabled and working individuals category. So this category applies to people who essentially lost premium free Part A due to going back to work, for example. Um, Medicaid covers their Part A premiums, but not their Part B costs. So basically, we have full benefit Medicaid only individuals who qualify for full Medicaid coverage, but maybe they don't fit into the QMB or SLMB categories. So anyway, that means these individuals may still have to pay Medicare cost sharing unless the state covers those costs, right? So all of this, like, what does it mean? Like, let's say all of that went over your head. Really, the bottom line is that it means not all dual eligible individuals receive the same level of assistance. Some get full coverage for Medicare premiums, some get only their Part B premium covered. Additionally, Medicaid policies vary by state, so cost sharing rules may be different depending on where someone lives. Some states cover all Medicare cost sharing for Medicaid enrollees. Others have limits to those payments. So some people might be responsible for out-of-pocket expenses. This gets really tricky. Like we could have a whole, probably semester-long session on Medicaid only. So I leave you with that. I leave you with that. What you need to know is that Medicaid is going to be very state specific. And because it is a joint program, it's going to vary in the level of assistance we have for dual eligible individuals. Okay, so for more on that, please check state websites for things like that. Go into this link I gave you with a brief that talks about all of the things you maybe need to know about these categories and eligibility for it. Okay, the next thing is, oh, okay, so this is also a resource that you can tap into that goes along with that brief I shared earlier. So this is a fact sheet that gives you some of that information easily condensed as well for you and your clients. This can be really hard, but essentially this can help you have a fact sheet about, what these different beneficiaries would have. Okay. Also, if you want to learn more about this complicated system, which it is, you can click here, and I'm pulling this. Ooh, I'm pulling my screen up because I had a little bit of a note that I wanted to share with you all. But essentially, the first three programs allow individuals to earn in the low to mid $1,000 per month, and couples $1,000 per month in income, with total assets of 8,400 for an individual, 12,600 as a couple. And those numbers were from 2024, which I wrote down in my little notes. But I do think that this is an important thing that you would essentially check for your Medicare savings and see asset limits, which then are going to help you determine the spend down piece that we'll talk about in the future. All right, so let's jump right into long-term services and support. So Medicaid does is one of the biggest ones to cover long-term services. Actually, Medicare doesn't cover it, right? So Medicaid offers a range of services, nursing facility care, adult day health programs, home health aid services, personal care services, transportation, case management, and more. So Medicare has limited coverage. I said Medicare doesn't cover long-term care. I mean that in the sense that it's more of like a patch, right? We talked about how Medicare covers certain things, like when you go into a skilled nursing facility, it pays for those short-term stays. It also might pay for outpatient PT, OT, and speech, but it's not broadly long-term care of what we would consider long-term care in our profession. It's labeled long-term care because it does provide a short-term stay in a nursing skill facility, especially if you qualify for it. So go back to slides and remind yourself of those qualifications, but essentially you can't be observation status, you have to be fully admitted. And I think I gave you some breakdowns of what those days would be. Okay. So who pays private long-term services insurance? Sometimes pay for those long-term care services that are past these 100 days or short-term stays. The problem with private long-term insurances is that they're expensive, and I rarely see people have them nowadays. It's really rare. I have had some people who have had them, and it's actually so helpful in us determining, what this person's eligible for to either have help in the home or to access a facility. Now, there's also, I want to say, restrictions on that. When I worked in Florida, what ended up happening is each long-term care insurance has partnerships where you can only access certain like in-home agencies that provide caregivers. So like a patient of mine used to have a long-term care insurance that she wanted to pay her current caregiver for, and that's not allowed because this person that was being paid out of pocket was someone that was external and not from an agency that was approved from the long-term insurance. So keep that in mind. Also, Medicaid is the primary payer for both institutional and community-based long-term services. I think that's more commonly what I would think is long-term services, or at least in this profession. And then caregivers who both spend and give up income, majority are women over the age of 50. So this is kind of like who pays for all of this. Caregivers do bear the brunt of the spending of our healthcare in our nation. And oh my gosh, I could geek out so much about caregivers. That is like my bread and butter. But we have a whole session dedicated to it. And up until up until now, I've been so good and not going too geeky on it. But I'm so excited for that session and might have to be a two-parter as well because there's so much to say about caregivers and their economic value, but also the financial precarity that they find themselves in. So there's a lot going on and a lot of disparities related to this that we need to keep in mind. Okay, moving on. And bear with me because my slides are janky even from far away. Anyway, so Medicaid is the primary payer for long-term services supports. We went over that last week in another graphic that I shared with you. So, one of the biggest things is that with few affordable options in the private insurance market, limited coverage under Medicare, those without resources really rely on Medicaid, which is managed by CMS, which, yes, it is managed by our current Department of Health person, which in this time is RFK. Um, and that's, pending TBD what's going to happen with that. But essentially, this is to show you that the total national long-term services spending, and this was in 2013. So in 2013, the total national long-term spending was $310 billion, dollars, with Medicaid covering 51% of total expenditures, followed by other public or other out-of-pocket spending and private insurance. So under Medicare, long-term services is limited. Home health services are only covered for beneficiaries who are homebound. There's a lot of assessments that include, who is going to receive these services. Personal care services are not covered, like, again, a home-based caregiver. And besides the nursing stay, that's kind of the limits that it has, which is why Medicaid is one of the biggest sources for long-term services. So here's also what you can see from this graph is that the older someone is, the more likely it is that they will need some sort of long-term help in the future. For especially this is for, and I'm like trying to make sure that I'm saying this right, but this is also for some self-care or household activities. So as you can see, there's definitely differences between the groups. Dual eligible individuals are the most in need, regardless of the age, versus overall, we see that people who are dual eligible have the highest need. Why is that important, right? Why is it important is because that means we're seeing a crossover of people who are older adults or people with disabilities having the most need for Medicaid in our nation. That's huge. That's huge because that's who it's impacting. That's who these policies and money that is potentially going to be cut, being taken out. These are the people it's going to impact. Um, yeah, and this is, obviously for 65 and older. There's also this graph that I wanted to show you, especially highlighting these disparities. So in general, this chart really shows that white, non-Hispanic, or non-Latinx older adults are less likely to have long-term services and support needs than their Black and Latinx counterparts. So that's huge, right? This is not uncommon that we see this disparity, but we are seeing that basically the needs are higher for people who are historically underrepresented in our nation. And money, which equates to access to resources as well, can exacerbate these issues. And we've talked about this in the assignments. I saw a lot of you talk about, the cycles of poverty, and that's the case here too as well. With low income without Medicaid, we're seeing that in this graph. So combined, this and the previous charts really should show you that disparities in later life don't just happen in a vacuum. They're really the results of years of cumulative advantage and disadvantage, which is why we talk about how this is not just aging. This is a life course perspective. Okay. This next graph is really looking at among all seniors with long-term services needs, many live in a home that needs repair to the interior or exterior. The repair needs may include things like flaking paint, broken lamp, accessibility issues, or it could be something, and my friend does this in Detroit. Actually, she helps fix houses, especially through government funds, which is interesting for this city of Detroit. And, lead is a big thing there too. So pest, tripping hazards, all those kinds of things that pose health hazards. Those are the things that they're looking at. And basically, poor housing conditions really reflect that maybe an occupant's limited income or ability to keep up on repairs is clearly a big need. But also, there's a huge body of evidence that we've noticed that indicates these conditions can also have very big effects on overall health and functioning. So, housing conditions really represent a challenge for programs, individuals trying to serve the population with long-term services needs, particularly since such repairs are not covered by Medicaid despite the impact on health. So, I say this because it highlights that, especially look at that dual eligible group. I mean, it's higher than the entire overall. So housing conditions are really important as we're thinking about where to invest money, what to think about. This is important to today's topic, especially on age-friendly communities. Last 2 weeks also were housing. So it's again a multifaceted issue that we need to keep considering. Okay. And then this figure is about the US spending over $400 billion dollars on long-term services care in 2020 and nearly 10% of all national healthcare expenditures. This is actually the slide that I showed at the end of class last week. So this is essentially to show you that Medicaid paid 53 billion on institutional care and 162 billion on care in the home and community settings. So again, when we talk about the biggest source of this for our older adults who are in the low income category, Medicaid is the biggest source. And so right now that's under threat, and that should worry us all because that is also not just an aging issue. It impacts all of us. It impacts all our families. Okay. So when I say home and community-based services, I definitely want to also be clear for people who may not be as familiar with the languages or don't really have never been exposed to like long-term services. I know people here have been different concentrations, whether it's children, youth, and families, anything like that. So I want to be clear, home and community-based services is part of what's considered long-term services. Um, essentially, this is something that was a major movement for long-term services because we realized people want to stay in their home. People don't tend to want to move out of their home unless they have to or unless there's other external reasons. But we saw a lot of people want, especially older adults, want to continue living in their home. So home and community-based services are a really important part of long-term services. Through Medicaid, home and community-based services are completed through waivers. Most states do waivers. Each state will have different processes and different waivers for what home and community-based services mean to that state. Um, Programs can provide medical and non-medical services, as well as other services that may help people stay in their homes and communities. So that might mean a lot of different things depending on the state. When I worked in the state of Florida, right? The state of Florida, home and community-based services, there was waivers you could apply for to have a caregiver in the home. So that's something that, would go through a waiver process. Sometimes you even have to potentially file claims, things like that, to be able to even obtain something like that. I also know that Medicaid sometimes, as part of this HCBS, has a program in Florida that partners with being able to pay family members to be caregivers if they're already especially engaged and have a rapport with the older adult. There's limits to that, of course, and that is part of our caregiving session, but there are limits to those policies, and we'll talk about them in the caregiving section. The last one I want to point out to you, and I know some people already have mentioned this during class, so I know that some people are familiar with these programs, but PACE stands for Program for All-Inclusive Care of the Elderly. And this is a bit different, but also based on a waiver. So someone who's on Medicaid could basically apply through a waiver or complete a waiver to obtain PACE as part of their long-term services benefit. To find out more about these waivers and the programs, especially home and community-based services, I did include a link here through Medicaid.gov where you can really check out and just remember that each state has its own kind of rules and like definitions of what this looks like. But if you can see here carefully, it says nearly all states and DC offer services through HCBS waivers, and they may operate these waivers as they want. And there's over currently 300 HCBS waiver programs active nationwide. So you would definitely have to check out which state you wanted to check out their home and community-based services programs. Okay, I'm gonna pause because I need to take a drink for a second. So give me a second. Okay, I'm back. So, just to give you an example of when we were talking and having a really rich discussion, which I appreciated, about the processes of like applying being very taxing and time consuming, leading to burnout and potential resources that go into that, plus, the quality of care. I wanted to bring this into that discussion because it's super important in our services for long-term care that we are abiding to quality to provide the best services for especially those who are most vulnerable and most in need. So this is through the mass.gov website, and it's called Mass Health Innovations. Mass Health, which is Medicaid in Massachusetts, is committed to the idea of quality, right? And so essentially it's a paid based on care outcomes and not volume of services provided. Because this is managed by the state, there had been some initiatives um, nationwide actually by Biden that were happening that really focused on quality in nursing homes, et cetera, especially for Medicaid beds and Medicaid clients. And so essentially, Mass Health Innovations has this commitment and goal, and this should be encouraging to everybody. I don't know how I haven't worked in the Massachusetts um, health insurance programs. So I would welcome your input on this. Make a note if you are familiar with Mass Health at your current work environment. But essentially, the movement is to pay providers based on the on care outcomes and not volume of service provided. So this is an initiative that Massachusetts began, a full statewide ACO program. This started in 2018 and it served approximately 850,000 mass health beneficiaries. Had to get that number correct. But Okay, sorry. For some reason, I'm having some glitches on my end in terms of managing the PowerPoint, but I just paused it and started again. So, let me just recap. So essentially, Mass Health, which is Medicaid in Massachusetts, has a program that they've been really committed to, in the state of Massachusetts that served, 850,000 beneficiaries, Medicaid beneficiaries here in Massachusetts. This was called the ACO program, so Accountable Care Organizations, and it started in 2018. And basically, they have three ACO models, and they are way too complicated to explain for this entire class. We do not have the luxury of time to cover all of them, but I put this here because most ACO provider organizations involved with the Medicaid program are also Medicare ACOs, and many also serve private insured patients. So this is really, really comprehensive in terms of restructuring mass health through ACOs with shared savings and mandatory, but limited up and downside risks for people. So I would encourage you to check it out. I would love your input, especially if you have worked with ACOs or if you have experience in your field placements or work environments that you've had mass health individuals. It would be super, super rich for us to discuss that in class. Just because I'm not familiar with mass health, and I do put it here because I have lived in Massachusetts for a while since I've been at BC, but have never been able to engage with the insurance companies here. So I would love your input on that. Okay, moving on. So we're now to the part of Medicaid spend down. So last week we talked about how Medicaid is a program that has eligibility criteria related to income and asset limits. So, what happens when someone doesn't meet that limit or they are not too far away from it? What are ways that we can address that, right? So, what we usually do as social workers and people who are enrolling people in Medicaid or are thinking about, hey, in the future you might need Medicaid, it's called Medicaid spend down. So if an older adult's income is too high to qualify for Medicaid, you can engage in spend down. So that's spending down your income and assets, usually medical expenses, usually through medical expenses, I should say, to qualify for Medicaid. So this is regulated by states. So again, this is where it gets complex, the weave, right? I mean, the web we weave with this system of really complex networks. But essentially, most states, including Massachusetts, have asset limits of around 2,000, a bit more for married couples, and it hasn't changed in years. Just think about that. It hasn't changed in years. So, this is important because each state also has its own, like, really, really confusing and yet and non-standardized spend down rules, right? They're not like a one size fits all. But in Massachusetts, the monthly income limits for an individual as of last year for nursing home costs it would be 12.55 a month. For home and community-based services, $2,829. And that's probably already gone up as of 2025. But this is for Massachusetts, right? Again, varies by state. You would in turn in terms of doing this above board, if that makes sense, you would have to submit medical documentation to the states to determine your eligibility. Most of the time, and I say this just because I've worked in Florida and Michigan, which is where I'm more familiar with these spend down processes. I actually did Medicaid enrollments in Michigan. So what what I'm trying to say with this Medicaid spend down is it can be complex in many ways. A lot of people reach this point and think I can just spend all my money in the last year before I can maybe get to Medicaid or before I need really big expenses for my health, or even, hey, I don't even qualify for Medicare yet, so I'm not going to spend down until I can become dual eligible. Like things like that, where people maybe wait until the last minute to do this spend down. Problem is, states like Florida and Michigan do look at a period of time. You can't just be like, oh, I'm going to spend all my money down and then qualify for this. There has to be a period of time that you do spread these expenses out so that it's not flagged, right? So sometimes that period can be 5 years of look back. Some states do less time, more, I don't know if more time. I haven't seen states that do more time than 5 years. But, in Florida and Michigan, I give as an example, was 5 years look back. So they would look at your income and assets over the past 5 years um, to determine your eligibility as an older adult. If you need extra help with this is something that I got acquainted with when I was doing Medicaid enrollments, and I found it very, very enlightening. So as you can see, there's a spend down period that is highlighted there, and I can't really quite see, but it says states can choose to set spend down periods anywhere between 1 to 6 months. So this is the period of spend down in a state with a 1 month spend out period. Person not covered, non-covered medical expenses must lower their income to the Medicaid limit each month to qualify for Medicaid that month. So this is for the spend down period, but that doesn't mean that it won't be flagged, right? So, okay, so I should clarify because this just reminded me of my days of Medicaid enrollment. But essentially, the spend down is different than the look back period. So the spend down is essentially the part of the Medicaid asset and income to meet Medicaid eligibility limits, that can be done within a shorter time. So the medical expenses, allowable spend down strategies are the ones that are allowed within that short time frame. The biggest part that I was talking about earlier about the look back period applies more about retrospectively reviewing someone's financial activity, which is what gets fishy or flagged to detect if there's been like improper asset transfers, right? Like I keep thinking about clients who had so even though you spent down in the 1 to 6 month period of the state, they looked back at their 5 years of activity and they saw that, someone transferred X to a family member, and that could be flagged as improper, and that could cause you to potentially have a penalty or potentially not get Medicaid eligibility. So you potentially would not be able to, and this applies as well for like long-term care benefits for a certain number of time. So like you could become ineligible for long-term care services. So this is important, and that's what I meant of like the 5 year period look back in terms of spend down, in terms of actual money and medical expense allowable spend down strategy, 1 to 6 months, depending on the state. The look back period could be 5 years, for example, of the retrospective view of financial activity to detect those improper assets transfers. Okay. Glad we clarified that because I was having a flashback to those Medicaid enrollment periods and it's really confusing when you're like, well, spend down says 1 to 6 months, but like what's that 5 year thing about? All right. So the Centers for Medicare and Medicaid Services are the agency, which I already talked about earlier, but basically it's within the U.S. Department of Health and Human Services. They administer the nation's major healthcare programs. CMS oversees Medicare, for example, Medicaid, CHIP, which is Children's Health Insurance Program, and the state and federal insurance marketplaces. So CMS collects and analyzes data and produces research reports, which, by the way, are a huge source of concern at this time because of certain banned research words or banned research types. So, CMS, the future of CMS research reports is kind of question marked right now. And they also work essentially to eliminate fraud and abuse within healthcare systems, which we obviously need those checks and balances. Um, so I guess like I put that here because you need to know who's a stakeholder, who's involved, what's the chain of command, right? If we were to go and advocate, we need to know who's the one running Centers for Medicare and Medicaid Services, who is our state representative for maybe the Department of Health pieces of our state. So anyway, and it is a state joint federal state program, so you do want to have those contacts and pieces in your mind. All right. The next slide here that I have is long-term care insurance. Um, Again, it's very uncommon nowadays, but just to give you a little bit of a breakdown, about 7.5 million Americans have some kind of long-term care coverage. In 2021, the cost in the Boston area, this was from the Genworth Cost Care Calculator, gave me these estimates, which is huge. So if you look at this is per month, home health care is around 6,000. These have all gone up, by the way. So like, I feel like I should probably update that. But in 2021, we saw that homemaker services were around $7,000, well, 6,292. I'll probably average up just to kind of give us what it would actually be like now that it's gone up. So home health care was around $7,000 for these services. Adult day centers were around $2,000. Assisted living was around $7,000. Am I reading that right? I feel like it's kind of blurry on my screen. But yeah, it was around $7,000 actually for assisted living. And for nursing home care, when it's a semi-private room, meaning you're sharing that room with somebody else, it was upwards of $14,000. Private rooms around 14,000, almost $15,000. So, yeah, long-term care is expensive. And it begs the question, how is our nation going to navigate through that? How is our nation set up for this, especially when we have a lot of our nation aging without our shift in demographics catching up to that. So this is just something really, really important for us to know in terms of, and this is in Boston, so of course this is going to be higher than in other states, but long-term care is a significant source of expenses for people. And as you all saw in your first assignment, when you don't consider those expenses and you get to that point in your life, it's virtually impossible to be able to afford that. So, what are some of the long-term care options that people have? So, although less common, people do have access to traditional long-term care insurance policies, either short or long-term. These can be very expensive and they may not pay for much. They also may have a lot of limits. So, in order to get one of these long-term care insurance policies, you need to be under 60 years old if you want to purchase this insurance because of the underwriting process, which is extremely challenging. Hybrid policies exist as well, where you get a life insurance policy with a rider. So with living benefits, which can be accessed, used to pay for long-term care, you pay up front or over time. And this isn't meant for me to go in depth into any of these, so you definitely will want to look up you definitely will want to look at this on your own. And, especially as people have been asking their family members about this is something that could be a great conversation to see if, obviously if comfortable, and your family situation better than I do, but if comfortable, this might be something to talk about, especially in terms of the underwriting processes that are involved in things like this. Then there's a deferred fixed annuity. So you put a large amount of money down into an annuity through an insurance company, and it would increase in value and pay for care when you need it. So it's a tax-free way to essentially get a fixed annuity thanks to the Pension Protection Act. So one major benefit is that there are minimal underwriting processes with no medical exam required. Underwriting meaning that there could be some essential processes that you have to go through before accessing your long-term insurance process. Just to give you an example of the underwriting process, um, that could look like this long-term insurance people looking at your past and current medical conditions, your, drugs, prescription drugs, pre-existing conditions, to basically assess the need for your long-term care. Those can also include, like for my clients, we've had cognitive impairments or assessments, which is a major reason to access long-term care services. Essentially, they're looking for the justifications to then withdraw money for that long-term care insurance, which involves underwriting. So yeah, anyway, more on that and I think I have a link, and if not, I also will include it. It's either on yep, right here. So on the previous slide, there's a link that you can access in order for you to take a look a little bit more about that. The other one that we talked about throughout the housing lecture was a reverse mortgage. So it used to be looked down upon as a predatory thing, but now it could be an option for somebody that really is in need and wants to stay in their home. Okay. This slide really talks about Medicaid or federal benefits. So there's Medicaid and then there's federal benefits through things like the VA. So veteran benefits include aid and attendance programs. Okay, like y'all, I gotta stop right here because I need to tell you, VA aid and attendance benefits have come in clutch for my veterans. Now, it's quite annoying to be honest to apply to one of these. There is documentation involved. Happy to talk through that with anyone. I know there's people that maybe have a VA placement already and know about these, but it can be quite a pain. And I used to fill these out all the time at the hospital, but it does require you as a social worker or health professional really knowing the language on how to help your client, right? For example, there's people that used to get denied VA aid and attendance at the hospital I was working out because they had cognitive impairment and they didn't technically meet like homebound status or whatever status they determined it was not the highest level of VA aid and attendance. So what ended up happening for that specific case is we had to talk to the wife about this form was filled out by another provider who didn't know the history of what dementia can do, right? So when you talk to caregivers and help fill these documents out, you really want to talk to me about the time that things were really, really in crisis because you got to us either because there's a crisis or because there's a diagnosis that caused you concern. So tell me about those concerns, and you can at that point take that and fill out these documents. These documents ask things like, does this person need assistance with X, Y, and Z? So obviously, you have to be careful because you still have to honor the honesty of putting down what is actually accurate of your patient because they are going to assess them regardless of your assessment or not. So you definitely don't want to lie on it, but you do want to um, highlight that cognitive impairment, for example, can bring um, ADL needs that are not the same as someone who has a physical or visible disability, right? And so it's important for us to continue to look at those kinds of things. And then aging service access points, ASAP, which is a contract with home care agencies, either through Medicaid or copay. So this is another benefit called ASAP that you should check out. I'm not as familiar with this one, and I don't know how it works in terms of the contract, but it's something that if someone's interested in it, we can talk a little bit further about. I highlight these just to give you some ideas of the programs that is either Medicaid or federal benefits. And then PCA programs, so through ASAP Medicaid program, clients hire their own caregivers who are paid by the state. So that's the one I was talking about earlier, that there's programs through Medicaid where a caregiver can act as an employee of the client, not agency or state. So this is important because there are some family members who could qualify for that added benefit of receiving a stipend for their care. Now, there's limits to this in terms of what family members do qualify, who doesn't. Um, but it is through Medicaid, so that older adult already has to be in financial need as well. Um, we'll talk a little bit more about this in the caregiving section because this is very policy related. So again, I'll keep putting a little pin on it because I don't want to take away from the caregiving lecture. Okay. The next thing I want to say is that more than half of the program, 73 million enrollees identify as Black, Latinx, Asian American, Pacific Islander, Indigenous American, or Alaskan Native. So when we talk about Medicaid being on the line for cuts, I reflect on all these groups that are going to be particularly impacted. In COVID-19, we saw that Medicaid disproportionately affected Black, Latinx, and Asian Americans who experienced higher overall rates of infection, hospitalization, and death. Women of color also experienced greater risks of maternal morbidity, mortality, and giving birth to a preterm or low birth weight infant. And then nearly 60% of those in the Medicaid coverage gap are people of color. So what does that mean? That there's people who are in real need of the benefits, who are not receiving the benefits, and who are under threat right now of not receiving as much coverage or even any coverage. So that should worry us, and it is something to keep paying attention to, and something that we, as practitioners and researchers, will keep on advocating for the voices that really need to be paid attention to. So I do have a YouTube video that I'm going to post later. Um, and it relates to this Medicaid health equity piece. I want you to take a look at it because it really relates, especially to the LGBTQ plus community, and some of the if I remember if that's the correct video. But there's a lawyer that had done, and let me just pull it up real quick. Give me a second. Let me pause it and then come back. Okay, JK, never mind. Blur that from your memory. But this isn't the video of the lawyer. That was actually related to supplemental security income. So I'll bring that into another class time, especially on who's excluded. I think that'll be a great session to have that specific video on. I do have a video that I want to share with you that I'm not going to play because it's 38 minutes long. But for those who are really interested in really understanding Medicaid on a deeper level, this is a training from the Robert Wood Johnson Foundation that was filmed. And so I think this is a great resource for you to learn essentially like the basics, or no, not even basics. These are like the more advanced Medicaid pieces, like how the program is administered, what the coverage gaps are, expansions, special populations, Medicaid daycare, Medicaid assisted treatment. So check it out if you're interested and let me know if you need any other trainings or things that you're interested in, which, by the way, you can also through state websites, there's times that they post trainings for health professionals that are free. So check those out. I used to do those all the time when I was in Michigan. All right. we will end there for the Medicaid lecture. I'm going to briefly pause to then go to some other content that I want to cover. All right, I'm back. And this is from the housing lecture. So I can't remember. I do think I covered this, but I want to go over it again. So this is from the mass.gov website. Massachusetts has a program with the Senior Circuit Breaker Tax Credit, which is offered by the Massachusetts Department of Revenue. And essentially, certain seniors who own or rent residential property in Massachusetts as their principal residence are eligible for refundable tax credit. So just to summarize, and there's a link in there that you can check out, but you have to be 65 and older. Your income has to be in these categories, whether you're single, head of household, or married. And the deadline is when you file your taxes. You can amend a previous return as well. But when you file your taxes, this is where you would qualify for this circuit breaker tax credit. Owners and renters qualify. So we talked about in the housing lecture that like it's a lot of home ownership privilege, but in this case, owners and renters qualify. So there's lots of eligibility criteria that I can't summarize all of it here, but it would be super important if you think any of your clients or yourself or anyone in your family qualifies. It would be really great to check out, especially now tax season's coming up. It's upon us. All right. I told you I had glitches. But anyway, speaking of taxes, many of you or your clients, older adults or not, qualify for tax prep, free tax prep. Many of you also could qualify for free tax prep as students. So the mass.gov website has a handy dandy find a tax professional to help with your taxes resource that I linked here so that you can spread the word coming up in tax season. I gave you a little quiz on this one last week. So the low income housing tax credit, just super briefly, what essentially is a federally authorized program for nonprofit and for-profit developers. So it's not for individuals, but it's for developers to promote construction of affordable rental housing. So it essentially gives an incentive to these developers to basically create more affordable housing, which is very helpful for communities that are vulnerable, including older adults. The other thing that I feel I haven't quizzed you on, but an important thing to keep in mind is Section 202 and Section 811 programs for the elderly or persons with disabilities. So within HUD, the most common one we hear about is Section 8. Now, Section 8 is not age specific, which is why I didn't like talk about it here. But we do know that this is a life course perspective. So Section 8 does matter for housing policies and vouchers. But in this case, the Section 202 and Section 811 are important because they do have that age and disability eligibility pieces in it. So as you can see, Section 202 program funds development of affordable housing for older adult households, and 811 provides nonprofits with funding to provide supportive for housing for people with disabilities, very and extreme low income persons as well. So more information on this is included here. There's links everywhere so that you can get more acquainted with these Section 202 and 811. I won't push you too hard on it, but do expect a question or two from this just so that you are familiar with the basics of this. In talking about, we talked a lot about different housing models, and I want to emphasize, right now the movement that we talk about in spaces like the Gerontological Society of America, in these spaces we talk a lot about models that are grassroots or like community organized. Creche is one of them. So Creche is the Charles River Episcopal Co-housing Endeavor. So we see intentional communities being brought about by churches and grassroots organizers who get the funding to be able to provide housing for people most in need. And so I bring this up because policy is at many, many, many levels, community included, grassroots included. All of that is part of the policy landscape. Creche is just one example. We also have Opus Communities from Two Life, which is a nonprofit organization. Just to give you a little bit of an idea, I actually had a student who worked at this Opus community last year, and she gave me a little bit of the eligibility criteria. So you have to be 62 or older. You do have to do 10 hours of volunteering a month. And you do have to participate in a one-time Opus share to help with capital costs. Monthly fee does include all staffing programs, dining credits, care coordination, internet, and utilities. And it's a life lease apartment. So you're not worried about losing housing, which is huge for our older adult communities. So check them out as well. This is nonprofit from Two Life. And I want to say she said there was a couple locations, like not just one. So check it out. I'm not as familiar, but she was, and I wanted to include it here because it was a great resource from last year. And then I did include briefs for you here just because you could get ideas for your projects for assignment two in terms of housing briefs for aging. And I won't go over them too much because I already went through this slide before. So, to the meat and potatoes of the things that I wanted to cover at the housing one that maybe we didn't get to have more of a discussion on. So, write down your thoughts because I would love to hear them when I come back. But this is more of like 2025, like what's going on in housing right now in 2025. What are some goals, proposals, and continuations in the housing landscape today? So, again, glitches. Anyway, so what's happening now in the current landscape, right? Medicaid currently covers long-term services and supports. We've gone over that, including home-based care, which helps low-income seniors or older adults avoid institutionalization. So avoid being leaving their home if they don't want to through home and community-based care. Um, that includes or could include, right? Because Medicaid is jointly funded with states. That could include home modifications, reduced rental assistance, those kinds of things where like it provides that support for people to be able to stay in their home without having to go into a facility that they might not want to. Um, in 2025, the proposed federal budget cuts to Medicaid could reduce funding for housing related assistance, um, which allows people to remain in their homes. So that's definitely a daunting thing. Um, that could also mean fewer home modifications, no more, even less services to help with wheelchair ramps, grab bars, um, maybe reduce rental assistance for people who are transitioning from hospitals to nursing homes. And then there's also a lot of pressure on state Medicaid programs to fill these funding gaps. So it creates that added pressure. There's also, in the current landscape, state level expansion of Medicaid housing assistance. So some states are counteracting federal cuts right now by expanding Medicaid funding housing programs under, guess what? The home and community base waivers, right? So some states are kind of going about this in a way that is friendlier to older adults and using these waivers. So some of those initiatives that are being led include Medicaid paying for housing navigation services, so helping older adults secure stable housing. So having a navigator or a case manager to help you find housing is really important. And that's one of the ways that home and community-based service waivers can interact with housing. So as you can see, like they're all interconnected. There's also, before I move on to the other one, there's also other examples of state-led initiatives, right? Like there's more funding for in-home personal care aides right now. There's rental assistance for older adults with disabilities. Like there's a lot of initiatives that are trying to help support expansions of people aging in place to reduce reliance on nursing homes, which actually could cost individuals and healthcare and the economy more, right? So should be probably a good incentive to people who want to save money for our nation. So, other things that are happening in the current landscape, right? Cities are legalizing more accessory dwelling units. So many state and local governments are loosening the zoning laws. Sorry, like my Spanish comes out, right? But loosening the zoning laws to allow more ADUs. ADUs can also be called, like my husband the other day, he's like, "Oh, you mean the in-law units?" I'm like, "What? What are in-law units?" I've always known them as ADUs, but he knew them as in-law apartments. So yeah, that's kind of what they are. Some people call it, other things, but this is what they are. We talked about them previously, but essentially what's happening is many state and local governments are allowing more of these to be constructed to increase housing options for older adults. Why would they do this? Well, ADUs help seniors live more near family members. They also, sorry, I keep trying to get ahead of myself, but I do want to cover this. So we talked about in the quiz that this allows people to live near family members, which is a huge thing. It does provide rental income for older homeowners. So like let's say an older homeowner did have an ADU, it creates a rental income from that. It also reduces housing costs for intergenerational households, right? So if you did have someone that was living with you, mom's coming to live with you, dad's coming to live with you, family members coming to live with you, this can reduce those housing costs by having accessory dwelling units and not having an entire other house next door. Um, then there's tax incentives that are happening right now in the current housing market for multi-generational housing. So some states are introducing tax breaks or tax credits for homeowners who create housing for aging family members. So in 2025, there's things like property tax exemptions for ADU construction in Massachusetts, especially, and in California. So, yay, Massachusetts for being one of the front runners for this. There's also state tax credits for home renovations that support older adults, so like making things more accessible. There was also federal proposals last year for multi-generational housing credits that covered costs of adding an additional dwelling unit or accessory dwelling unit. So this is really cool, right? Like these were proposals that were happening in 2024, 2025 now. Um, don't know where the status of all of these are because we have known that some of these have been placed on halt. And now with the roller coaster that things are, Medicaid is on the line. So I don't know how this is going to impact ADUs or if that's going to be an incentive for the current administration. But these are proposals that have been happening before the election. And then we talked about 202, which supports housing for older adults, and Section 811, which is for people with disabilities. And these are seeing federal grant expansions that are supposed to happen in 2025. Don't know the status of that, but that's kind of where it's at. We didn't see a freeze yet, so I'm hopeful. But yeah, so this is supposed to receive expansions, which is good for older adults and people with disabilities. Some of those changes include more funding for older adult housing developments, additional rental subsidies for lower income older adults, and new pilot programs to integrate housing within healthcare services. That's huge, right? Like when we think about us being in healthcare and how sometimes when people get discharged from the hospital, like what are they going to do for housing? That's huge. So these are pilot programs that were being proposed in 2024, 2025. The other thing I wanted to say is there's a couple things that were happening too in terms of there's a there's a proposal to bring back HUD's Aging in Place pilot program, which integrates medical care in senior housing developments. So I think this was born from COVID, if I'm not mistaken. You can fact check me on that. I don't have my Google pulled up because I have to have the presentation up. So my apologies, but I'm happy if you look it up for us. But essentially, this proposal of aging in place pilot program was created to have medical care in older adult housing developments because we haven't seen a lot of people receive home health care or just like health medical care like your providers going to your home. We don't see that a lot, and for it to be expanding to older adults and that supports aging in place, it is so important to continue that. I don't know where it's at. I don't know if it's frozen. I haven't heard much about housing policy lately, so stay tuned on that. Let me know if you have any updates. There's also partnerships between senior housing providers and Medicare Advantage plans that have been occurring. HUD has raised fair market rent limits as well, allowing older adults to use vouchers in higher cost areas. And then direct HUD housing to landlord payments. And I apologize. I actually realized that I didn't throughout this use GSA approved language. So replaced every senior and elderly thing from this slide with older adult to be a little more inclusive and aware of how we speak about older adults. But back to this. So, direct HUD to landlord payments was also an initiative that was happening, basically making it easier for older renters to secure housing. I'm not going to go super deep into any of these. I'm just giving you some updates so that you can stay up to date. And then senior specific housing vouchers. So some cities have allocated Section 8 vouchers exclusively for older adults in 2025, which is exciting because Section 8, again, doesn't have like an age limit or restriction. So it's cool that there's something related to expanding this or exclusive for older adults. We talked about the low income housing tax credit, which is an incentive for older adult housing development. Okay, so I'm going to stop right there so that I can go to the next slideshow for our class. All right, I'm back. So now we're going to cover transportation and aging friendly communities. This is going to hopefully not be as long as the other presentations. So thank you for bearing with me. And I want to be respectful of your time. It's kind of funny because like Zoom doesn't give me an option to see like how long I've been recording for. So I apologize. I do think that this is going to be under, so don't worry about it. Okay, so let's get into transportation and aging friendly communities, which by the way should be all aging friendly communities, right? Like all inclusive. Um, so as I was reading through a couple of things, especially here at BC. The Center for Retirement Research at Boston College estimates that around 21 million vested retirement accounts in the US are inactive. So I say this because, and these were meant to be announcements, but I kind of want to highlight this here because as I was reflecting on your assignments and things like that, and as we're covering Medicare and Medicaid as they're huge insurance companies, I think about just how much we have inactivity, even when people are eligible for services, um, which is wild. And like that money is set aside, and yet people aren't accessing it, which just shows you a huge gap in literacy, right? So I won't cover all of this, but this is just to show you an opinion piece that came out that's just so powerful related to um, essentially people not tapping into money that they might have saved up. So that's important and important to remind your clients of those. So last year, no, 2 years ago, I found this resource from the American Council on Aging, and I want to point out, American Council on Aging is actually part of a for-profit corporation. So when you consume news and go into resources, you want to know like the motives of why people put out these things. So just keep in mind, like this website's a great resource, but they're also trying to sell you a service at the bottom of the page. So just keep in mind when you access these contents, like what they're for. But this is a very updated, like Medicaid spend down handy dandy tool. So keep that in mind. This is also a great policy brief that I wanted to show you related to Medicaid and whole person integration. Again, I wanted to weave the discussion of last week where we talked about quality assurance, especially as it comes to Medicaid. This is a great brief for you to read. So, whole person care takes holistic view of health and encourages health providers and systems to consider individual, family, community, and population level factors. So, this is a cool brief. Check it out. This is just part of the announcements that I had for today. that are part of this specific lecture. Um, PACE. So I briefly, not barely, briefly talked about PACE, but essentially PACE includes many aspects of whole person care models, which is part of that brief I just shared. And there's several here in the region, so check them out. Essentially, I think we have one in East Boston, if I'm not mistaken, but they serve adults living all over Boston. There's some that are in Arlington, so north, and many more throughout the state. So there is, and even by having all of these, I mean, there's so many more. I want to say there's one in Watertown too, but there's so many more throughout the state, and yet there's greater need than there is supply. So that should give you a little idea as to Medicaid helps cover some of this for some older adults needing long-term services. Some people pay out of pocket for it as well if they need it. And then other times it comes from a combined coverage of Medicare, Medicaid for dual eligible individuals. So just PACE is such a great resource though. So if you're not familiar at all, please, 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 please check them out. It is such a great resource. I've seen so many clients benefit so much from it. Um, this is like a map of PACE that this is part of the announcements I had for today, but also part of aging friendly communities, right? Aging friendly communities, because PACE is a program that's all inclusive and holistic, meaning while it's not open to like all ages, it is focused on well-being and essentially people being able to be met where they're at in their needs, whether it's through socialization activities, whether it's through fitness, um, whether it's just through a milieu of services that they offer. So it's a great resource, and I will continue advocating for it because I love it. Um, there's also community behavioral health centers, which are a one-stop shop for a wide range of mental health and substance use treatment programs. The Commonwealth statewide CBHC network includes 29 centers located in communities across Massachusetts. They offer immediate care for mental health and substance use needs, which I've had to refer clients to, both in crisis situations and more routine checks. Um, but routine outpatient services are available for all Mass Health members, which is what you should know, like Medicaid, Mass Health, may also be covered by some commercial insurers. Okay, the next thing I wanted to talk about is as I was reading the talking points for this week, I want to highlight some of the things that I saw from your talking points. So, one of the first things I saw is the eight domains of livability and how that related to social determinants of health. I absolutely love that connection that people made to social determinants of health. I also really liked people highlighting the online intergenerational home sharing websites that are not accessible to some older adults. So some of you pointed out that, while the idea is great, that there's accessibility issues in delivering information, which I wholeheartedly agree, and we need to do better at. Which I also am always encouraged by future generations and how we disseminate information. I hope that this increases literacy for our older adults and people who are caring for older adults. And then when some of you did the reading on driving, which was so cool, that you gave me your thoughts on that, but people essentially in their talking points talked about, one's abilities, not age, should be an indicator or dictate if you can drive. And obviously that's not black and white, right? Like there's gray and case by case basis areas. And then some people had questions about what about transportation options for people with mild cognitive impairment? This is something I constantly dealt with at the hospital. So we'll cover some of that in this lecture. Some other talking point summaries that I think were pretty cool is that safer roads, driving, signage, road markings, and intersections benefit everyone. Absolutely, yes. Incentivizing older drivers to take a refresher course was a really cool idea. Ensuring a discount, maybe a win-win question mark. I like that proposal. That was pretty cool. And then making roads more accessible instead of kicking whole populations off. I put a huge thumbs up to that. I do think that, there's so much to be said about accessibility of roads and especially here in Massachusetts, tell you the truth. Wow. But yeah, accessibility is a huge point for us to advocate for our older adults. I'm gonna pause to take a quick sip of my water. Give me a second. Okay, I'm back. Yay. All right, so these were just some of the talking points that stood out to me. If we were in person, I would love to talk about it, and I am gonna pick your brain about it because this is such a cool topic. Okay, so transportation, let's talk about it. That's part of the aging friendly communities. But so transportation, so most of the time when I talk to someone and I ask them, and wait, is my screen sharing? There we go. When I talk to some people about who they think is most at risk for accidents, you know, being on the road and dangerous, people often say older adults immediately. Um, this is really interesting because, and actually, when you look at the data, right, the risk of motor vehicle crashes is higher among teenagers ages 16 to 19 than among any other age group. Teen drivers are group have a fatal crash rate of almost 3 times as high as drivers 20 and older per mile driven. Huge. I mean, that's a huge thing. And like people keep having more ageist towards older adult views of this approach. And so that's, things to consider, right? Because this is something that most people don't think about as advocacy for older adults, but this is where we get to dispel the narrative that older adults shouldn't be looked at as a problem or shouldn't be boxed into um, give me 1 second. For some reason, one of my applications opened in the background. Give me 1 second. Okay. Sorry, I'm back. For some reason, my background app opened. So, yeah, so anyway, when we look at who's especially at risk for these crashes, males are actually higher risk in terms of having higher death rates from car crashes than female drivers in the same age group. So we have a lot of people who have sexist views about this as well. Teen driving with teen or young adult passengers and newly licensed teens. So this is pretty different than what our nation sometimes assumes um, about who our drivers are, right? Or who our quote unquote at risky drivers are. Okay, so the other piece, aside from the assumptions that we need to dismantle and information that's put out there about driving, is accessibility of transportation. I totally wish we were in person because this is my favorite part of like asking people like if you had to rate a percentage of like which city has the highest accessibility and transportation, what would you say? Um, for example, if I were to ask you, do you think New York City has close to 100% accessibility for older adults? What would you say? Because New York City, right, has a really large transportation network. um, Trains everywhere, right? Metro, buses, all kinds of things. So let's say you said for practice sake, because this is often what I get is, well, I would think it's like 80%. Well, actually, New York City is 41% accessible. Um, or I guess like 41% of older adults estimated to have poor transit access. So it's on a scale of like, 0 to 100%, where someone could say, "Oh, I have um sorry, I'm like trying to translate what this like kind of like the measure is the poor, not the like better. If you were to say it's accessible, essentially someone would be like, yeah, it's kind of mostly accessible, like 60% accessible. However, almost 50-50, right? Where New York City is supposed to be one of the most accessible cities, 41% of older adults 65 to 79 were estimated to have poor transit access. And that's actually good, right? Like that's actually considered the standard, the best that we have so far in the nation. Many places are actually far worse. Oh, again, I wish we had like a show of hands of like which states you think have the worst access. I might save that for the little quiz next week, actually. So I want you to read this on your own, and that way I'll quiz you on this. But essentially, there's places that have far worse access, and I can't wait to quiz you on which one you think has higher or poorer access compared to New York City, which I mean is most of them. But I want you to guess which one has the highest inaccessibility. But anyway, I'm getting off on a tangent on my own. So I'm sitting here by myself, getting myself on a tangent. So let's move on. So we covered like not just the prevalence of driving and transportation, differences in conceptions about older adults being the most at-risk drivers. But then we talked about accessibility mattering in this. Another thing that's specific to Massachusetts is ride match. So I know most of you are familiar with this, and if you're not, check it out. I don't know if anyone had this like issue with it, but when I was looking at this in certain areas, there's just like not a lot of options. Interestingly, a lot of the options are located in, guess where? Very affluent communities. I saw some ride shares very concentrated in Newton area, which we know is just historically an affluent community. And so I think about how this adds to that accessibility piece in terms of barriers. Here's the official website if you want to check it out in terms of ride share, in terms of like ride connections that you could help older adults connect to. Um, then there's also policy considerations in terms of driving. You should have seen this in the readings for this week, but there's people who are on the side of using blunt instruments for assessing for driving, right? Eligibility. So someone, maybe if age 50, 85 and over, you just can't drive if you're 85. You have to renew your license in person if you're 85. Those could be like the more bluntish instruments that people could use. The precise-ish instruments would be someone if like policies or states that look at if you're 85 and older, then you have to take a vision test, a hearing test, and a cognition test to renew your license. So the idea here really is that using chronological age as a proxy for risky driving can have can be tricky, right? So there's people who, there's a lot of solutions being proposed, right? I actually had a student last year who talked about requiring letters from doctors to say if they have concerns about driving, or requiring letters from doctors to state that older adult is good to drive. So these are things that one can revoke a license, right, for an older adult if you're a health practitioner. I've had to do it myself. It's not pleasant, but it's not a picture of just age, which we keep coming back to, and something that we as a nation need to continue moving the needle on. What might work and not work about these ideas? Like if you think about these ideas, what could work about using these like really precise or blunt instruments and being able to assess for drivability, right? Or risky driving. So what could work, what couldn't work? So carrots and sticks, right? Often we have a mix of bag of carrots and sticks that work best. So in the carrot side, there's free or discounted goods that we could offer and services for older adults who participate in safety courses, for example. And again, I say this because there's a lot of solutions being thrown out there, but there's it has to be it's like a mixed bag, right? Because age cannot be the sole indicator of anything that has to do with driving, right? Like age is a determinant clearly for Medicare, clearly for Social Security, clearly for CSEP, for certain services from Older Americans Act. So there's clearly like this really big line of who's defined as an older adult for certain services. When it comes to driving, this can become really tricky, right? Just because someone's an older adult doesn't mean that they can't drive. While we do know that people deteriorate in certain health aspects, such as vision, hearing, that doesn't, there's mechanisms, like there's people that wear bigger prescription glasses when they're older and can still drive. So we can't just use age as the only proxy for this. So carrots could be, and this is just um a proposal from a student that I had last year that could be helpful in kind of giving ideas about this. Carrots could be like offering these incentives, right, for older adults to participate in courses. Sticks could be things like penalties for not taking part of safety courses or losing your license for not following guidelines for your age. So there's just a mixed bag of what could work for our nation in terms of driving. And I can't wait to hear where you lie in terms of safety for the older adults, safety for the roads, what should be considered in the carrots and sticks of the policies that we consider for driving. And like, what are some reasons? I would love to pick your brain as to what are some reasons that you would consider in terms of um, restrictions or laws for driving in our nation. So I would love to hear that. And this is probably better suited for us to talk about in class. So I'll make sure to add it to our little quiz as a discussion point. Okay, so moving on to age-friendly networks, right? So, and give me a second, I'm gonna take a drink because I'm parched.